Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in the Conversation with Cancer Expert series of podcasts, I have with me Dr. Peter Voorhees, who is one of the most well-known authorities in multiple myeloma. He's professor of medicine and chief of the Plasma Cell Disorders Division at Levine Cancer Institute in Charlotte. He's been instrumental in some of the latest advances in this disease, including CAR-Ts, bispecifics. So we're really privileged to have him today on the program to talk to us about a presentation that he made at the just recently concluded ASCO 2025 meeting. This is the long-term follow-up of the CARTITUDE-1 study. So, and a provocative question, which I'll, ask him at the end is, are we starting to cure multiple myeloma? So welcome, Peter.
Thank you. Thank you, Ravi. It's good to be here.
So as far as the CARTITUDE-1 study goes, can you put it in perspective for us? What do we know about it? And then obviously we will see how this longer term follow-up adds to what we know.
So CARTITUDE-1 was a phase 1b/phase 2 study that looked at the safety and efficacy of the BCMA targeted CAR T cell product, ciltacabtagene autoleucel, also known as cilta-cel or Carvykti commercially. And, this is a study that was conducted a number of years ago now, and these patients are now on long-term follow-up. And the basis of the presentation at ASCO was really looking at these longer-term, efficacy results and safety results for patients treated with this CAR T cell product. And just to put the results into perspective, this data from the Locomotion-1 study, I think, are very helpful. So Locomotion was a prospective registry study that looked at outcomes for patients who had relapsed or relapsed refractory multiple myeloma that had been previously treated with the three core pillar of myeloma therapeutics, so the CD38 antibodies, the proteasome inhibitors, and the immunomodulatory drugs. So a very similar patient population to those that were treated in CARTITUDE-1. In fact, the eligibility criteria were nearly identical. And what you can see here on this slide is that the median progression-free survival in Locomotion-1 in this patient population was only 4.6 months. And the median overall survival for this group was actually 12.4 months. So I think it's just important to remember those numbers and put that into perspective, when we review what we saw with CARTITUDE-1 with long-term follow-up.
So could you remind our audience about the trial design?
Yeah, so it was a single-arm study. There were 97 patients who were that underwent leukapheresis and actually received the cilta-cel product. They received standard lymphodepletion chemotherapy with fludarabine and cyclophosphamide for 3 days, followed by CAR T cell infusion using a target dose of 0.75 times 10 to the 6 CAR positive T cells per kilogram. And, with long-term follow-up, patients on CARTITUDE-1, were invited to participate in what's called CARTINUE. And actually the data from this long-term follow-up comes from this CARTINUE study, because we really, as we're thinking about CAR T cell therapies, we need to think about unexpected, late-term potential toxicities, right? And for those patients that were still responding to therapy, how long are they going to respond? What does overall survival look like? And that's what the CARTINUE study is really seeking to address.
So what was the patient disposition on the study?
So, again, 97 patients were treated with cilta-cel. Unfortunately, there were 17 patients who passed away before experiencing progression of their multiple myeloma. A number of those were due to infectious complications, and that data has been previously reported and published. And it really speaks to the need for rigorous supportive care for these patients as they go forward with treatment, recognizing that this was a heavily pretreated patient population. There were 46 patients who experienced disease progression, and 13 of those are on post-disease progression follow-up as part of the CARTITUDE study. And then there are impressively 32 patients who are progression-free, so their disease has not relapsed and alive, 5 years or more after cilta-cel infusion. That's 1/3 of the patients who are still alive and without progression of their myeloma after a single dose of cilta-cel.
Very encouraging. So, what does the long-term progression-free survival overall look like?
Yeah. So the median progression-free survival has been previously reported and was published in the Journal of Clinical Oncology by Tom Martin and others. So the median progression-free survival was just over 34 months, which in and of itself is remarkable because again, going back to that locomotion study, the median progression-free survival there was 4.6 months. So to extend that to 34 months is something we've never really seen before. And with longer term follow-up, again, when you go out 5 years from the cilta-cel infusion, you have 33% of the patients from the study who are still alive and without progression of their multiple myeloma. And we've never seen that before in a study in such heavily pretreated patients. Recall that the median number of lines of prior therapy that these patients had received before going into the CARTITUDE-1 study was 6. So this is really an unprecedented result.
Truly. And what do we know about these long-term responders?
So Mount Sinai, was the largest enroller to the CARTITUDE-1 study, and their standard practice for all their patients who achieved a complete response to therapy was to undergo an annual bone marrow examination with minimal residual disease testing and an annual whole body PET CT. And of the 12 patients that they had on the study that had achieved complete response, all of them were MRD negative, and all of them were in complete metabolic response by PET CT imaging for 5 years or longer after their cilta-cel infusion. So this is really quite remarkable. It's not just that their disease is being held at bay. I mean, these are patients, who are sustaining deep responses for 5 or more years after their cilta-cel infusion.
So, are there subsets that you can identify prospectively that are likely to do well in the long term?
So absolutely. So one of the things that's interesting is that if you look at patients in remission and alive for 5 years or longer versus those that progressed within 5 years, there's no difference in the proportion in either group of patients with high risk cytogenetic features. So, high risk cytogenetics did not predict in a negative way for these long-term remitters. Similarly, there was a very similar number of patients with extramedullary disease for those who responded for 5 or more years versus those who relapsed within 5 years. So while median progression-free survival may be shorter for patients with extramedullary disease receiving cilta-cel, it doesn't necessarily preclude you from being one of these long-term remitters. When you look at triple class refractory disease, so again, myeloma that's refractory to CD38 antibody-based therapy, proteasome inhibitor-based therapy, immunomodulatory drug-based therapy, there's really no difference between the two groups. The baseline characteristic that was clearly different between these two groups of patients was the burden of disease going into the CAR T-cell infusion. So for those patients who had progression-free survival for 5 or more years after cilta-cel, the median bone marrow involvement with the myeloma was 5% versus 24% for those that relapse within 5 years. And if you look at soluble BCMA levels, which is a surrogate marker for burden of disease, the median was 36 for those progression-free for 5 or more years versus 58.5 for those that progressed within the first 5 years. So it really speaks to the need to control the disease and go into the CAR T-cell infusion, with a lower burden of disease.
And are there characteristics of the product itself that portend for better outcomes?
So I think, the two pieces of information on this slide that are of significant interest. So when you looked at the CAR T cell product itself before infusion into the patient, um, those patients that achieved progression-free survival for 5 or more years had a higher proportion of naive T cells in their CAR T cell product. And when you look at characteristics of the CAR T cell product after infusion into the patients at peak expansion, there's a couple of things that you can see here is that those patients that had a higher effector to target ratio, so a higher proportion of CAR T cells at peak expansion relative to disease burden, those were the patients that were more likely to be in remission for 5 or more years after cilta-cel therapy. And if you look at the numbers of central memory CD4 positive T cells at peak expansion, they were higher for those patients, who achieved remission for 5 or more years after their CAR T cell treatment. So it really gets at this issue again of optimizing the effector to target ratio going into CAR T cell infusion, but it also suggests that a more immune fit CAR T cell product, whether you measure that by the numbers of naive CAR positive T cells in the product before infusion, or whether you look at the number of central memory T cells at peak expansion, it suggests that more immune fit product is going to lead to better longitudinal outcomes.
And what about overall survival?
So we have a median follow-up now of over 5 years, so 61.3 months to be exact. And the median overall survival came out at 60.7 months. So just over 5 years, median overall survival. Again, going back to the locomotion study, the median overall survival there was 12.4 months. So this is basically, 5 times, what we're seeing in that particular study, which is really quite remarkable. And I think sets a new benchmark for therapies in this space.
Truly. And what do you know about the safety with longer term follow-up?
So the last time, safety was reported for CARTITUDE-1 was back at the annual Society of Clinical, the American Society of Clinical Oncology annual meeting back in 2023. So we have an additional 28 months of median follow-up since that last report. And, importantly, there was nothing seen that was unexpected or attributed to cilta-cel. So in particular, there were no new cases of Parkinsonism. Now, we certainly have seen cases of Parkinsonism in this study, and those have been previously reported, but there were no new cases reported with longer follow-up. There were no new cases of cranial nerve palsies. There were 2 secondary primary malignancies that were reported. One was an adenocarcinoma of the lung, and one was a squamous cell carcinoma of the anus. Neither of these were attributed to cilta-cel. There were no new secondary hematologic malignancies, which I think is important to recognize. There were 2 neurologic events that occurred with longer follow-up. So there was one grade 1 taste disorder, and then there was one case of encephalopathy that was attributed to hepatic dysfunction after a patient received IVIG therapy. So neither of these were attributed to cilta-cel as well. And then, again, I had mentioned earlier, that there were some early deaths, in part due to infection-related issues in this heavily pretreated patient population. We only saw 4 new grade 3 infections with longer follow-up. And, this far out, none of those were attributed to cilta-cel therapy. So it does look like the risk of severe infections drops fairly significantly over time.
So, what are your key takeaways from this presentation?
Well, I mean, the key takeaways, are the fact that, with just a single dose of CAR T cell therapy, cilta-cel specifically in this case, in a heavily pretreated patient population, 1/3 of these patients are alive and progression-free 5 years later, which is something that we've never seen before. And again, going back to the Mount Sinai experience, not only are these patients progression-free and alive 5 years or longer, they're MRD negative and they're in complete metabolic response by PET CT, which is really quite remarkable. I think it's important to note that patients with high-risk disease features, whether you define that by cytogenetic abnormalities or the presence of extramedullary disease, they were just as likely to fall into this, group of long-term remitters as those that had standard risk, cytogenetics, or those that did not have extramedullary disease. And again, and this, speaks to kind of what's happening now in the new studies with cilta-cel. The patients in long-term remission had more immune fit drug products and a higher effector to target ratio at peak expansion, which is something that I think we can leverage to greater effect in earlier treatment. And then again, this median overall survival of 5 years is really remarkable and just really speaks to how active this particular therapy is, and again sets a new benchmark for new therapies in this space.
So where do you think the field is moving?
So CARTITUDE-4, as some of the audience may know, was a randomized phase 3 study that looked at cilta-cel versus two different standard of care therapies for patients with relapsed myeloma. The difference was this was earlier in the treatment paradigm. So this was specifically for patients who had had 1 to 3 prior lines of therapy. And as many know, cilta-cel outperformed standard of care therapy, in that particular study, both with regards to progression-free survival as well as overall survival. And if you look at the progression-free survival curve on this particular slide from CARTITUDE-4, looking at that standard risk patient population who got cilta-cel, you do begin to wonder, are we actually curing some of those patients? With longer follow-up, is that progression-free survival curve going to remain flat? So that's really exciting to see. So my anticipation is that the CARTITUDE-4 data will look even better than the CARTITUDE-1 data with longer follow-up. And again, kind of getting to this issue of optimizing effector to target ratios and the use of more immune fit CAR T-cell products, applying cilta-cel in the newly diagnosed setting is particularly attractive, where we're very effective at controlling the burden of disease with induction therapy, and the patient has had less, treatment for their myeloma, so they should have a more immune fit, CAR T-cell product with which to work. So CARTITUDE-5 is a randomized phase 3 study, that's looking at the use of cilta-cel as part of frontline therapy for newly diagnosed myeloma patients who are not eligible for transplant, and that is finished enrollment. And then there's the CARTITUDE-6 study, which is a randomized phase 3 study that's looking at the use of cilta-cel consolidation, as part of frontline therapy for newly diagnosed myeloma patients who are eligible for transplant. And in fact, in CARTITUDE-6, patients are randomized to either a transplant consolidation strategy or a cilta-cel consolidation strategy. So that study is going to test transplant and cilta-cel head-to-head to see if cilta-cel will produce better long-term outcomes compared to transplant.
So we are finally curing some patients with myeloma, or is it too early to say?
So, a proposed working definition for cure in multiple myeloma has been, proposed. So this is achievement of MRD negativity at 10 to the minus 6 level of sensitivity, which is the best we can do as far as measurement right now. Complete metabolic response by PET CT for 5 or more years off your myeloma therapy, no maintenance or anything. So if you've achieved that level, you're potentially cured. Now, we have a third of the patients on CARTITUDE-1 that have met those criteria essentially. At least, those that had MRD testing and had PET CTs done, it appears that the majority of that third of patients is going to meet that criteria. Will there be some patients that relapse? Yes, I do think that will occur for sure. But I also think that there are going to be patients who remain MRD negative in complete metabolic response on their PET CTs. and pass away years later of unrelated causes. I think those patients are cured. So, yes, I do think we are curing some patients with this therapy. I think we could be curing more patients with this therapy using it earlier in the treatment paradigm. I think that there'll be more patients that meet this criteria from the CARTITUDE-4 study, and certainly more in the upfront studies with CARTITUDE-5 and CARTITUDE-6. And, I think it'll be important to follow these patients from CARTITUDE-1 as part of the CARTINUE study, further to see how many of these patients are actually going to relapse. And we can revise, our working definition of cure in multiple myeloma over time, depending on, how things play out. But, I think that this is a first right step towards cure. I'm always cautious with the word, so I do want to put the caveat with the word potential in front of cure. But this is really exciting times in the myeloma field for sure.
I think that is indisputable, and hopefully I can have you back in a few years so that you can take that potential out of that and say, yes, we are curing myeloma. There's no doubt about it.
Yeah, that would be absolutely amazing. I do think we have the tools to do it in hand right now. It's just a matter of how to best apply them. And I think that the supportive care piece of it remains crucial, because there's real side effects associated with CAR T cell therapy for sure. I think we're getting better at navigating those potential pitfalls over time as we learn. But we will always have to strive to do better. But very exciting times for sure.
Well, I want to thank you for everything you're doing for furthering the cause of treatment for these patients and for coming and sparing your valuable time to educate the audience. And I hope I can draw on you in the future again. Uh, and thank you very much again.
Absolutely. Thank you, Ravi, for having me.